Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. To get into the show, we have Maria Mba Wright and Carol Reavis. Maria is a pediatrician. Carol is a pediatric nurse, and together they co-wrote the Kevin MD article. You need to ask these questions to teens starting hormone therapy. Maria and Carol, welcome to the show.
Thank you so much for having us.
So I'm going to ask each of you just to briefly share your story and journey to where you are today. Maria, why don't you go first?
Yeah, so I've been a pediatrician now for 20 years. And in my current practice, one of the questions that we ask our patients is, and this is during our physical exams, is whether they have a family history of an early heart attack or stroke. And specifically for men under 55, women under 65. And so if the answer is yes, we do some screening tests. And one of the tests that we're looking into, one of the labs, is an elevated lipoprotein A. Lipoprotein A at elevated levels is a genetic condition that is associated with early heart attacks and strokes. So over the years of doing these tests, this screening, I noticed that there was elevated levels noted in South Asian descent patients, African Americans, and Hispanics. And so I started becoming curious as to why this was happening. And so I contacted our genetics department to see what type of counseling are we giving these families. And so one key thing is, if the patient is ever put on estrogen or estrogen-containing medication, they need to be on aspirin supplement to avoid a risk of stroke. And so then I would counsel my teens about this. And one of my teens actually took this to heart. So after she transitioned to adult medicine, she had gone to see a gynecologist because she was having breakthrough bleeding. Yeah. And so she was offered birth control pills, which is a standard treatment. And apparently she yelled at her provider. So the provider went ahead and asked and contacted me to say, why is this teen yelling at me? And so
what was she saying when she was yelling at the provider? What was she yelling about?
They told me that this is something about, this is harmful. Why are you giving me something like this when my doctor told me that this could cause harm? Something along those lines. And so when I proceeded to ask to explain to the gynecologist as to why this would be, I realized she was not aware of lipoprotein A and what the implications were. And so then I realized, because just giving it, for example, to this patient without aspirin, for example, could put the patient in harm's way. And so this is where I realized we need more awareness. And that led me to write a first article. And the article we're going to discuss today is a derivative of these initial articles. So this is where I'm coming from.
Sure. And we'll get into that article in a little bit, but Carol, why don't you just quickly introduce yourself?
Hi, I'm Carol Reavis. I've been a pediatric RN for 26 years, and I've worked the last 17 years with Dr. Wright in the clinic, coming from extensive acute care pediatric experience. I got involved in this article because it was rare for us to hear about a 16-year-old having a stroke. And also,
so tell me that story about that 16-year-old having a stroke.
Well, we found out about it kind of in a roundabout way. Dr. Wright had come to me saying that she had heard from genetics, if I'm correct, about the 16-year-old Caucasian male who had a history of migraines for 8 to 9 years and then had a stroke and was in intensive care in Northern California. And I was just amazed that this is something we don't see or hear about. And then that led to the reasons why Dr. Wright found out about the elevated lipoprotein A, the history of migraines, the factor V Leiden. That got me starting about my own husband's untimely death at an early age due to a heart attack, and his father dying very much the same way. And then that was like, would this have been a factor?
Sure.
That's how we started on all this.
All right. So your article that both of you wrote is titled, "You Need to Ask These Questions to Teens Starting Hormone Therapy." So Maria, tell me the issues and the events that led up to you and Carol writing this article.
Well, so again, the catalyst for me, when I found out about this 16-year-old teen that had a stroke at 16, and then the workup that found that he had a lipoprotein A level of 249, normal being under 40.
Hmm.
And he was is a carrier of factor V Leiden. The other thing that was found is that his father actually had passed away a year or two before at an early age of a widowmaker's heart attack. And the grandparent had also passed away at an untimely fashion at early age of a heart attack. And so then my question was, what if this particular teen decided to change genders? Because this is something that is real today.
Yeah.
Well, what would be the case here? I'm thinking this is a kid that we need to think about. And so then I started asking, how are we screening kids that are on hormone therapy, especially the transgenders? And I realized from discussing with my specialists in my group that everyone was doing something different. And so then I thought, well, it may be a good idea to standardize what we're doing so that we make sure that we're not unintentionally putting patients in harm's way, that we need to pause first. Do they have a condition that makes us think maybe the estrogen may not be the best therapy for them? Maybe we need to do something else.
As part of your screening questions before you start someone on hormone therapy, so you mentioned lipoprotein A as one of them. What other questions do you ask in the exam room?
Yeah, so we ask if they've had a personal history of lupus. We look at hypertension, migraine with aura. So if there's a family or personal history of thrombophilia, all these conditions actually would make us pause and say, well, maybe we need to consider a different therapy instead of what we are about to give, such as birth control pills.
Sure. And Carol, tell us some of the other cases that you and Maria have seen that have associated hormone therapy with blood clots and other hypercoagulable conditions.
Well, as I had mentioned earlier, in our clinic, we do birth control counseling almost on a daily basis. We see teens frequently. I would have to say that we didn't experience anything directly in our clinic as of yet, but we heard a lot about the celebrity news of strokes in young adults. And so that was kind of like, boy, this is now starting to come out. We started our brainstorming in January, February of this year, and all of this news started to come out over a period of time. And as we were refining and rewriting and getting everything up to speed.
So tell us about one of the celebrities. I think you had mentioned one in the article.
Yes. Well, the first one was Hailey Bieber. And what we had read was that she had not been screened by a medical doctor. And I don't know how she obtained her birth control. It was also discovered she had a PFO. So
what exactly happened to Hailey Bieber?
She had a stroke.
Okay.
And she was a lucky one as far as sequelae goes. But this is what we're trying to decrease the risk of by getting the information out.
Sure.
I wanted to add to that, actually, two things. One, just to add more information. So it turned out when they did the workup to look at what happened, what doctors had told Hailey. So she had the birth control pills that were given, but also she had COVID, the PFO, and had been traveling from, it looks like France, from Paris to Los Angeles. So all of these factors contribute to having this stroke. And, this is not something uncommon. For celebrities, they travel a lot, but when it comes to COVID, when it comes to even a PFO, and actually just to add to that, I actually have a parent in her late 30s who actually came in, and I've known them since her kids are now 15, and she had a stroke. And I asked her, what caused this? And they told her, oh, it was a PFO. And now she's older and she's dealing with just living with a stroke. And actually it's almost it's not really a pleasant experience.
And Maria, before starting someone on hormone therapy, do you do a panel of blood work? Is this all gathered through history and family history? How do you screen?
So first, the questions that we ask, but then also the vitals. We check for blood pressure. We check to make sure they're not pregnant. And the weight, height. So it's mostly history and vitals, and then the urine screen. Yes.
And then what kind of specific questions about the history or answers to your questions that would raise red flags in your mind?
So one, a family history of an early heart attack or stroke. If they have headaches, sometimes they don't even know what a migraine with aura is. But if they've had headaches, that's something that makes me think twice about what we're doing. Any family history of clotting or personal history of clotting, medications also matter. And so those are some of the basic questions that we do ask.
And Carol, in the article, it wrote that there were special challenges regarding the transgender patient. So tell us about some of those special situations.
Well, currently we have, I would say, about 5 to 6 transgendering youths in our clinic, and they're on testosterone for transgendering from female to male, but they're also on perhaps Depo-Provera or combined hormonal contraception. So their risks are increased. So that's what we deal with. We give them their testosterone as prescribed, and we check a blood pressure. I do anyway. I check a blood pressure on occasion to see how that's trending, and it's always stable, thank goodness. But that's about it for now.
All right. And then, Maria, in terms of these additional risks, do we have any data or numbers in terms of the additional risk because of the additional hormones that transgender patients generally are on?
So I don't think so. From my research, we don't have numbers, but I think this is where I want to start in terms of looking at a trend. When it comes to transgender, at least in the practice that I have, it's fairly new, the treatment. It's been a few years that we started this process. And I think, and I'm hoping that there are going to be studies that show what the numbers are. But again, the awareness and even having articles that talk about side effects or what could happen if you're on hormone therapy for a long period of time, the data isn't out there as much yet. But I'm hoping that I'm contributing to starting that trend.
So, Maria, you mentioned that there was a little bit of variability when it comes to screening among pediatricians in your practice, and I'm sure pediatricians nationwide. What are the guidelines, or are there any guidelines when it comes to screening patients for lipoprotein A and other risk factors before starting hormone therapy?
So I would say that at least in my practice, we actually ask that question about the family history. I don't think that there are specific guidelines. We know to ask some questions. We know to check for the pregnancy test. We know to check a blood pressure. But that is one of the things also, the point of this article. There isn't a standardized form of screening patients before we start anything. Everyone's doing something different. We all know some of the basics, but we are not asking all the questions. And I think this is where hopefully, even with this podcast, we can raise some awareness to let's start talking and getting, whether it's the MD, the nurse practitioner, all the providers in different specialties, pediatrics, gynecology, family practice, that we all are asking the same or at least the main questions.
We're talking to Maria Mba Wright and Carol Reavis. Maria is a pediatrician. Carol is a pediatric nurse, and together they co-wrote the Kevin MD article. You need to ask these questions to teens starting hormone therapy. Now I'm going to ask each of you just your take-home messages to the Kevin MD audience. Carol, why don't you go first?
I would say that we all know how draining the sequelae is from a heart attack or stroke in the medical community. The general population doesn't think about that on a daily basis like we know and do. So if we can decrease the odds of those risks and inform our patients to be more aware of their genes, that genes are more than looks and blood type, that's the message we want to get out. And perhaps we'll be the ones to set the guidelines, or at least draw attention to needed guidelines.
And Maria, your take-home messages to the Kevin MD audience.
Yes. So first of all, for providers, this is a call to action to screen patients before starting hormone therapy, to ask questions as to whether the patient has had a family history of early heart attack or stroke, or a personal or family history of thrombophilia, or of lupus, or of headaches, migraines with aura, so that we can pause before starting a medication. And then also rescreening with every refill, annual refills, because our histories change. And then finally, making sure that the patient understands that if their history or personal history, family history changes, to reach out to the doctor because that might dictate a change in therapy. And then for the audience, personal history, family history, knowing this is important and can determine your treatment plan. And then also make sure you understand, do your research, ask questions so that if you're going to be on a medication for a long period of time, understand what the long-term risks and benefits are. And finally, for the audience is to get regular checkups, because with that, if your status changes, you get hypertension, for example, then you know to contact your provider. I was placed on birth control 3 years ago. Now I have hypertension. Do I need to change my therapy plan? And hopefully as a team, we can avoid bad outcomes, at least help avoid bad outcomes.
Well, thank you to you both for sharing your time and insight. And thanks again for being on the show.
Thank you so much for having us.
Thank you, Dr. Poe.